Hello and welcome. Let me ask you a question. If you have diabetes or you care for someone who does, what do you believe is the single biggest mistake you could make today? For most people, the answer comes immediately. Eating a slice of cake, having a sugary soda, or skipping a dose of medication. And while those things certainly aren't ideal, I'm here today as a specialist in the health of older adults to tell you that the number one most dangerous mistake is something entirely different. It's a mistake that millions of seniors and their doctors make every single day with the absolute best of intentions. The title of this video calls out the number one blood sugar mistake, and you might think it's just another lecture about diet. It's not. The most dangerous mistake, and this is backed by extensive research from institutions like Johns Hopkins and studies published in the Journal of the American Medical Association, is something called overtreatment. It's the well-meaning but misguided effort to push blood sugar down so aggressively that we create a new, more immediate, and often more life-threatening problem: hypoglycemia, or dangerously low blood sugar. For many seniors, the biggest daily threat isn't a high number on the glucose meter. It's a number that drops too low. In fact, a landmark study revealed a shocking statistic. 1/3 of older adults who were hospitalized for a severe hypoglycemic episode died within 3 years. This isn't a long-term risk we're talking about. This is an immediate, clear, and present danger. Over the next few minutes, we're going to dismantle the old, outdated rules of diabetes management for seniors. We're going to build a new framework, one that prioritizes your safety, your independence, and your quality of life right now. I've structured this conversation into 6 key areas, 6 common but fixable mistakes that all lead back to this central theme of overtreatment. We will cover everything from the timing of your meals to the specific medications you might be taking. We'll talk about why the A1C goal your doctor gave you 10 years ago might actually be harmful for you today. And most importantly, we're going to get to that number one mistake, the core misunderstanding that puts so many people at risk. And you'll definitely want to stick around for the end, because I'll give you the exact words to use to start a new, empowered conversation with your own doctor. My goal today is to replace your anxiety with confidence and to give you, whether you're the patient or the loving caregiver, the tools you need to navigate this journey safely. And just a quick but very important reminder: the information in this video is for educational purposes and is based on current geriatric medical research. I am not your doctor. Every person's health situation is unique. Please always consult with your personal healthcare provider before making any changes to your medication, diet, or treatment plan. They know your specific health history and can provide guidance that is tailored directly to you. Our goal here is to help you ask better questions and be a more informed partner in your own healthcare. All right, let's begin. We're going to count down from mistake number 6 to the number one most critical error. Coming in at number 6 is a problem that feels deeply personal but is incredibly common: struggling with medication adherence. Now, when we hear the term non-adherence, it's easy to jump to the conclusion that it means being forgetful or careless. I want to be very clear. That is not the case. In my experience, this is almost never about a lack of caring. In fact, it often comes from a place of caring too much. A study in the medical journal Pharmacy found that medication non-adherence rates can be as high as 55% in elderly patients. And the reasons are complex. It's not just about forgetting. Let's imagine a common scenario. It's 8 a.m. You have one pill you're supposed to take with food. Another one has to be 30 minutes before food. Then at noon, there are 2 more. And at bedtime, there's an insulin injection and another pill that can't be taken with dairy. This is the reality of polypharmacy, managing multiple medications, and it is mentally exhausting. It's a full-time job that nobody trained you for. On top of that, there's the fear of side effects. Maybe a pill makes you feel nauseous, or another one makes you dizzy. Over time, you start to associate the pill with feeling poorly, and a part of your brain starts resisting it. It's a perfectly human reaction. The science behind why this is so dangerous is straightforward. The diabetes medications you're prescribed are designed to work over a specific period, in a delicate balance with the food you eat and your body's activity level. When you miss a dose or take it at the wrong time, you throw that entire system into chaos. For example, if you miss a morning pill but then eat your regular breakfast, your blood sugar can spike to unsafe levels. Conversely, and perhaps more dangerously, if you accidentally take a dose twice because you couldn't remember if you took it the first time, you could drive your blood sugar down into the hypoglycemic danger zone we talked about earlier. I remember talking to the daughter of a patient, a wonderful woman who fit the caring Carol persona perfectly. She was so frustrated with her father, saying, "He just won't take his pills right. I set them out for him, but half the time he forgets." When we sat down with her dad, he confessed with tears in his eyes that he was overwhelmed. He had 7 different bottles, and the small print was confusing. He was so terrified of taking the wrong one that sometimes his anxiety paralyzed him, and he took none at all. He wasn't being defiant. He was scared. So here is your action step. This week, declare war on complexity. Go to any pharmacy and buy a simple 7-day pill organizer with compartments for morning, noon, evening, and bedtime. This is the single greatest tool for medication safety. It externalizes your memory. You don't have to remember if you took your pills. You just have to look at the box. Second, link taking your medication to an existing, non-negotiable daily habit. For example, you will take your morning pills right after you brush your teeth, or you'll take your evening pills the moment you turn on the nightly news. This creates an automatic trigger. The red flag to watch for here is if your medication schedule still feels too complicated even with these tools. That is a perfect reason to schedule a medication review with your pharmacist or doctor. You can say, "My current regimen is very complex. Is there any way we can simplify it? Are there longer-acting versions of these drugs or combination pills we could consider?" Pharmacists are masters of simplification. This isn't about being forgetful. It's about building a system that sets you up for success. Now, that idea of a system, of a predictable routine, leads us directly to our next point. Because the pills you take are only one half of the equation. The other half is the fuel you give your body, which brings us to mistake number 5. Mistake number 5 is believing that what you eat is the only thing that matters, while ignoring when you eat. The real enemy for stable blood sugar is irregularity. We live in a busy world. Maybe you have a doctor's appointment that runs late, so you skip lunch. Or perhaps you're just not very hungry in the morning, so you have your first meal of the day around noon. Many people believe, "Well, I didn't eat, so my sugar won't go up. No harm done." This is a profound misunderstanding of how diabetes medications work. Think of it this way. Many common diabetes drugs, especially sulfonylureas and insulin, are like a prepaid ticket for a train that is scheduled to leave at a certain time. When you take your morning medication, you've essentially told your body, "A shipment of glucose is about to be used. Get ready." The medication starts working, lowering the sugar in your blood in anticipation of the food that's coming. But if you then skip the meal, The train leaves the station with no passengers. The medication does its job. Your blood sugar drops, but there's no incoming food to replenish it. The result is a classic medication-induced hypoglycemic event. You can suddenly feel shaky, sweaty, confused, or profoundly weak, all because of a scheduling mismatch. A study in the journal Nutrients highlighted that irregular meal timing is a significant risk factor for glycemic variability. Those wild swings from high to low, which is incredibly stressful on an older adult's body. I had a patient, a lovely gentleman named Arthur, who kept reporting episodes of extreme dizziness and anxiety around 11 a.m. We checked everything: his heart, his blood pressure, his medication doses. Everything looked perfect. Finally, I asked him to walk me through his morning, minute by minute. He said, "Well, I take my pills at 8 a.m. with a cup of black coffee. Then I run my errands, and I usually grab a bite to eat around 1 or 2 p.m. And there it was, the aha moment. His medication was peaking precisely at the time his body had the least amount of fuel, causing his blood sugar to crash. He wasn't sick. He was just out of sync." The action step here is to embrace the power of consistency. This doesn't mean you have to eat a huge 5-course meal every 3 hours. It means establishing a predictable rhythm. Aim for 3 modest, balanced meals at roughly the same time each day. If you know you're going to have a busy day or a late lunch, plan for it. Keep a small, healthy snack with you. A handful of nuts, a cheese stick, a small apple with peanut butter. Something with a bit of protein, fat, and fiber to provide sustained energy. The red flag is any pattern of feeling dizzy, shaky, or off between meals. That's your body's alarm bell. It's signaling an energy crisis. Don't ignore it. This is a critical piece of data to share with your doctor, as it might mean your medication or your meal plan needs a simple adjustment. We've talked about the routine of taking your pills and the routine of eating your meals. Now, let's go one level deeper and look at the pills themselves. This brings us to mistake number 4. Mistake number 4 is assuming that the diabetes medication you were prescribed years ago is still the right one for you today. This is particularly true for a very common older class of drugs called sulfonylureas. You might know them by names like glipizide, glyburide, or glimepiride. Now, I want to frame this with empathy. For decades, these were go-to drugs. They are effective at lowering blood sugar, and they are inexpensive. So if you're taking one, it's likely because at one point, it was considered the standard of care. Your doctor made a perfectly reasonable choice. However, the science of geriatric medicine has evolved significantly. A major study in the Journal of the American Medical Association, JAMA, Internal Medicine, analyzed over 77,000 veterans and found that patients on these sulfonylurea drugs had a significantly higher risk of death from any cause compared to those on a different, more modern drug called metformin. Why? The primary reason is their high risk of causing hypoglycemia. Here's a simple way to understand how they work. Imagine your pancreas is a sponge full of insulin. Most of the time, your body gives it a gentle squeeze when it needs some. A sulfonylurea drug, however, comes in and gives that sponge a hard, forceful wring out, releasing a large amount of insulin, whether you need it or not. It doesn't matter if you just ate a big meal or if you haven't eaten in hours. The drug is going to wring out the sponge. This indiscriminate action is what makes them so risky for older adults, who may have more variable appetites or activity levels. This is a key part of the overtreatment problem. We are using a sledgehammer when a more precise tool is needed. I remember a patient, a retired school teacher, who had been on glipizide for 15 years. She was a model patient, always took her medication. But she came to me because she had 2 bad falls in 1 month. She was terrified. She was losing her balance and her independence. As we talked, it turned out both falls happened in the late afternoon, on days when she had been busy gardening and had a smaller lunch. Her medication was wringing out her insulin, but her body, tired from the physical activity and with less food on board, couldn't handle the drop. Her blood sugar was plummeting, making her dizzy and causing the falls. She didn't have a balance problem. She had a medication problem. The action step is to become an informed consumer of your own prescriptions. At your next doctor's visit, I want you to feel empowered to ask this specific question. I've been reading that some older diabetes medications carry a higher risk of hypoglycemia for seniors. Could we review my current medication list to see if there are newer, safer options for me? Notice this isn't accusatory. It's collaborative. You're opening a dialogue. The red flag that demands this conversation is if you are experiencing any symptoms of low blood sugar, even mild ones like shakiness or a brain fog, while on one of these medications. It's a sign that the drug's sledgehammer effect might be too much for your body. Discussing alternatives like metformin, DPP-4 inhibitors, or GLP-1 agonists, which tend to work in a more glucose-dependent way, could literally be a life-saving conversation. All right, let's just take a quick pause here. We are halfway through the 6 biggest mistakes seniors make in managing blood sugar. We've covered the critical importance of a consistent medication routine, the danger of irregular meal timing, and the hidden risks of certain older classes of drugs. These are the foundational building blocks of safer diabetes care. And if you're finding this information valuable, if it's giving you a new perspective, I would be so grateful if you took just 1 second to tap that like button below. It really helps the video reach more people, more worried Williams and caring Carols who need to hear this message. Thank you for that. Now, let's move on to mistake number 3, which shifts our focus from the tools we use to the target we're aiming for. Mistake number 3 is chasing an outdated A1C goal. For years, the magic number in diabetes care was 7.0%. We were all taught, doctors and patients alike, that an A1C under 7.0 was the ultimate goal to prevent long-term complications like eye, kidney, and nerve damage. If you've spent the last decade feeling immense pressure to hit that number, I want you to know your diligence and effort are commendable. You are doing exactly what the medical community advised. But here's the controversy we now face. For many older adults, aggressively treating to reach that target does not significantly reduce the risk of heart attack or stroke, but it dramatically increases the risk of dangerous hypoglycemia. The very treatment meant to prevent a future problem was creating a much more immediate one. This is why the official guidelines from the American Geriatric Society and other leading organizations have changed. They've embraced a more individualized approach. The science now shows that for a generally healthy older adult with a long life expectancy, a target of 7.0 to 7.5% might still be reasonable. However, for an older adult with multiple other health conditions, cognitive challenges, or a life expectancy under 10 years, a much more lenient A1C target between 7.5% and 8.5% is often considered safer and more appropriate. Let me say that again. An A1C of 8.0%, which would have been seen as a failure a decade ago, is now considered a success for many older adults. The primary goal of modern geriatric diabetes care has shifted. It is no longer just about preventing possible complications 20 years down the road. It is about preventing a fall, a hospitalization, or a trip to the emergency room tonight. I had a patient in his late 70s who lived in constant fear. His previous doctor had him on a strict regimen of insulin and pills, and he was terrified of his A1C creeping above 7.0. He checked his sugar 6 to 8 times a day. He wouldn't go out to eat with friends for fear of his numbers going up. But he was also experiencing frequent, mild lows that left him feeling drained and anxious. His life had shrunk. After a long conversation about his overall health and what he valued, which was energy and social connection, we agreed to relax his A1C goal to around 8.0%. We were able to reduce his insulin dose. The change in him was remarkable. The lows stopped. His anxiety melted away. He told me, "I feel like I got my life back." He was living better, and more importantly, he was living safer. Your action step is to start a conversation about your personal A1C goal. At your next appointment, ask your doctor this powerful question. Considering my age and my overall health, is my current A1C target still the right one for me? Or would a slightly higher target be safer by reducing my risk of hypoglycemia? This question shows you are informed and thinking critically about the risk-benefit trade-off. The red flag is simple. If you are experiencing any episodes of low blood sugar, in your effort to meet a strict A1C target, that target is almost certainly too aggressive for you. It's a sign that the cure is becoming more dangerous than the disease. This focus on the dangers of hypoglycemia sets the stage perfectly for our next point. We've talked about the right goals, the right meds, and the right routines. Now we need to talk about the core fear that drives so many of our decisions. This brings us to mistake number 2. Mistake number 2 is focusing exclusively on the fear of high blood sugar while underestimating the immediate danger of low blood sugar. Let me be clear. Chronic, uncontrolled high blood sugar is absolutely a serious problem that can lead to devastating complications. Many of you live with a deep-seated fear of those complications, things like blindness, kidney failure, or amputation, perhaps because you witnessed a parent or an older relative go through it. That fear is valid, and it has likely motivated you to take your health seriously, which is a good thing. But we have become so conditioned to see a high number on the glucose meter as the enemy that we fail to recognize that for an older adult, the low number is the more immediate assassin. A blood sugar reading of 250 milligrams per deciliter is a problem to be managed. A blood sugar reading of 50 milligrams per deciliter is a crisis to be solved right now. Hypoglycemia in older adults can present differently and more dangerously than in younger people. Instead of the classic shaky and sweaty feeling, it might manifest as sudden confusion, dizziness, blurred vision, slurred speech, or extreme weakness. It can look exactly like a stroke. This confusion can lead directly to a fall, and a fall for a senior can be a life-altering event. A broken hip can be the beginning of a cascade of health problems that leads to a loss of independence. Think back to that terrifying statistic from the beginning. In one study, a third of seniors hospitalized for a severe low were no longer with us 3 years later. High blood sugar is a long-term war. Severe low blood sugar is a sudden, brutal ambush. I'll never forget a call I got from the emergency room about a woman named Eleanor. She was 82, lived alone, and was fiercely independent. Her neighbor found her on the floor of her kitchen, confused and unable to get up. The ER team was working her up for a stroke. But a sharp nurse checked her blood sugar. It was 42. They gave her glucose, and within 15 minutes, she was back to her sharp, witty self. What happened? Her doctor had recently increased her insulin to try to get her A1C down from 7.8% to 7.2%. The new dose was just a little too much. The resulting low almost cost Eleanor her independence and could have easily cost her her life. The action step here is twofold. First, you and your loved ones must know the signs of low blood sugar, both the classic and the atypical ones, like confusion or dizziness. Second, you must always be prepared. You should have fast-acting glucose available at all times. That means glucose tablets, gels, or even something as simple as 4 ounces of juice or regular soda. If you experience symptoms, check your sugar if you can. If it's low or if you can't check it but feel the symptoms, immediately consume 15 grams of fast-acting carbs. Wait 15 minutes, and then check again. The red flag that requires an immediate call to your doctor is any episode of hypoglycemia that requires help from another person to treat, or any fall or period of confusion that you cannot explain. These are not minor events. They are medical emergencies that signal your entire treatment plan needs to be reevaluated. And that brings us to the final, most important point of our conversation today. We've laid all the groundwork. We understand the risks of certain meds, outdated goals, and the immediate danger of lows. All of these pieces come together to form the number one blood sugar mistake seniors make every single day. The number one mistake, the geriatrician's most urgent warning, is letting the fear of long-term complications drive you into the immediate danger of overtreatment. It is the great paradox of modern diabetes care for seniors. In our noble quest to prevent the problems of the future, we create the crises of today. It is the combination of a too strict A1C goal, pursued with high-risk medications, that leads to the life-threatening reality of hypoglycemia. This is the mistake. It isn't one action, but a flawed philosophy of care that prioritizes a number on a lab report over the quality of a person's daily life. It's when we cause a person to fall and break their hip in the name of preventing a potential kidney problem 20 years from now. That is a bad trade. This happens because our healthcare system is often fragmented. The eye doctor wants your A1C perfect to protect your vision. The kidney doctor wants it perfect to protect your kidneys. But it is the job of the patient, the caregiver, and the primary doctor or geriatrician to step back and look at the whole person, to ask, what is the net effect of this aggressive treatment on this person's life right now? Is the benefit of slightly lowering this A1C number worth the daily risk of a fall, of confusion, of hospitalization? For a growing number of older adults, the answer, according to the best medical evidence, is a resounding no. This is where empowerment becomes the most powerful medicine of all. The final and most crucial action step I can give you is to arm yourself with the language to change the conversation with your healthcare team. This is not about defying your doctor. It is about becoming a partner with your doctor. You need to shift the focus of your appointments from "what is my A1C" to "how can we optimize my safety and quality of life?" Here are some phrases you can use. You can walk into your next appointment and say, "Doctor, I've been reading from the American Geriatric Society, and I want to talk about my risk of hypoglycemia. Can we discuss a care plan that prioritizes preventing lows, even if it means having a slightly higher A1C target? Or, I'm concerned that my current medication regimen might be putting me at a high risk for lows. Could we review it together and discuss if there are safer, more modern alternatives for someone my age?" And for the caregiver, for caring Carol, you can say, "I'm worried about my mom's safety. She's had a few episodes where she seemed confused and dizzy. I'm concerned it might be low blood sugar from her diabetes treatment. Can we talk about de-intensifying her regimen to make it safer?" These questions are respectful, informed, and collaborative. They open the door to a new kind of conversation, one centered not just on lab values, but on your life. So let's bring this all together. Today, we have dismantled the outdated, one-size-fits-all approach to diabetes in older adults. You've won a new understanding that managing medication adherence is about building smart systems, not about willpower. You've won the knowledge that the timing of your meals is just as crucial as the content. You now have the wisdom to question if older, high-risk medications are still right for you, and the confidence to discuss your personal A1C goal with your doctor. And most importantly, you now see with absolute clarity that the number one mistake is overtreatment, and you are now empowered to protect yourself and your loved ones from its immediate dangers. You are no longer just a passive recipient of care. You are an active, informed, and essential partner in your own health journey. Now, I would love to hear from you. In the comments below, please share which of these points was the biggest aha moment for you. Was it the idea of a safer A1C goal? The risk of certain medications? Sharing your experience can help so many others in this community feel less alone. And if this deep dive has been helpful, if you feel more prepared and less anxious than you did a few minutes ago, please be sure to hit subscribe and ring that little notification bell so you don't miss our future videos. We're all in this together. Thank you so much for spending this time with me today. Be well, stay empowered, and I'll see you in the next video.